iTech welcomes all the participants for today's National Distance Learning Seminar series. Today's topic is Approach to an HIV Positive Client, and speaker is Dr. S. Anuradha. Dr. Anuradha is the Director Professor of Medicine at Maulana Azad Medical College in New Delhi. She is also the Nodal Officer of ART Center and the Program Director of the COE in HIV at Maulana Azad Medical College. She did Masters in Infectious Diseases from the London School of Hygiene and Tropical Medicine, University of London. She is the recipient of Fogarty Fellowship in HIV Medicine. She is also the member of Technical Research Group, ART and Research and Development at NACO. We welcome you, ma'am, for today's NDLS session. I would request Dr. Anuradha now to kindly take over the
Good afternoon, everybody, and welcome to today's NDLS session. And it is really a privilege to be talking to you about a very important topic, which is approach to an HIV positive client. What this session actually plans and will be talking about in the next almost 45-50 minutes is what do we do when a person who is detected to be HIV positive comes to an ART center. What is the further course of action and how are we going to approach such a client? So the first thing to remember is that as soon as any person is detected to have an HIV infection, whether it be through an ICTC report, whether the person is carrying a report from any private lab or from anywhere else, whether the patient is admitted to an inpatient ward, as soon as a person is detected to have HIV infection, the first thing that must be done is that that person or client must be referred to the nearest ART center. This is going to link him or her to have access to comprehensive HIV services which are provided through the ART center. So linkage of every person who is detected to have HIV infection to the ART center is the first step or the cornerstone of providing comprehensive HIV care services to this person. So once a person who is HIV infected and is carrying a report of being detected to be HIV positive comes for the first time to an ART center, that is what is called the first assessment. So let us now look at what all can be done or may be done during this first assessment when this client is first seen in the ART center. So the question that gets asked is, who actually performs this first assessment? Who does this first assessment? Is this the counselor at the ART center? Is it the staff nurse? Is it the care coordinator? Is it a medical officer, or is it all of these? Well, the answer to that is that each and every one of these personnel who are part of the ART center team have a very important role to play in doing or in performing the first assessment of this client. The counselor has a very important role. The staff nurse and care coordinator have their own well identified roles, and of course the medical officer and the senior medical officer or the medical personnel of the ART center have a very key role in performing a medical assessment of the person. So actually this first assessment is not done by a single person, rather it is done as an assessment by the entire ART team, and so that is important for us to recognize and remember when the person or a client who is HIV positive comes to the ART center. So the first thing that must be done at the ART center, and that is being done at all ART centers, which we are very well aware of, is that the client needs to be registered at the ART center, and as a part of this registration process, one needs to complete all the processes of registration or all the protocol of registration, which includes address proofs of acquiring the telephone number, other documentation which need to be filled. It is very important to remember that at times certain documentations or other physical documents may not be present with the patient for the first time. However, you need to inform the person or the client that these information or these documents need to be provided probably at the next visit. Why do we stress so much on the process of registration? Well, of course, it is important not only to establish the demographics, meaning where is the patient coming from, what is his residence, is he from urban, rural, what kind of background the patient has. So it is very important not only to establish the demographics, but it is also extremely crucial in two important activities. If later on the patient for some reason becomes missed or does not come for follow-up, or later on gets reported as LFU, means he has missed more than 3 clinic visits, this information is very crucial in tracking and tracing the patients. So it is very important to complete the process of registration. Also, for accessing many of the state government and national social and benefit schemes, many times these documents, for example, certain numbers, the address, the telephone number, sometimes even the Aadhaar card are required for accessing these schemes. So it is important to remember that please complete the process of registration, and it is here that the community care coordinator, the staff nurse and the counselor have a very, very important role to play. After the registration process is complete, then you need to get other family related details of the patient while initially talking to him or her. Is he single, married, separated? Does he or he have a spouse or a partner? Have they been tested? We shall talk about this a little later. A social structure and identification of caregiver is very important. And the CCC and the staff nurse have a very, very important role in helping the PLHIV or the HIV infected person familiarizing himself or herself with the ART center, its flow and procedures. Because somebody who comes new into the center is actually really raw, does not know where to go, how to go from point to point, because there are so many activities that are happening. So it is important that the CCC and the staff nurse help the patient or the client in identifying what all activities are there and help him in or her familiarizing himself with the ART center flow and its procedures. So if you look at the assessment of an HIV infected client, there are 3 assessments that we are going to talk about. The first will be the clinical assessment. The second will be the laboratory assessment, and any other assessment like assessment of social structure, support mechanisms, any other networks, any other psychosocial assessment. So these are all parts of the other assessment that are equally important, and sometimes we tend to neglect them because they have a very important bearing on the how the patient comes, including the follow-up, the adherence, and these are very important questions and assessments that need to be done by the ART centers. So why are we assessing the patient, and what does all this assessment actually lead to? So what this assessment leads to is, first, after the clinical assessment and some lab assessment, we are able to stage the HIV infection, and we know which stage of HIV infection the patient has presented in. By screening the patient and evaluating the person, we are able to screen and diagnose any ongoing opportunistic infections that need to be identified and then appropriately treated. We are also able to determine any psychosocial factors that may influence the disease overall. For example, addictions. Not only do they affect or influence the disease, they also have an important influence on the overall way the person presents to the clinic. It also has implications on adherence to visits as well as to treatment. During this process, we are also able to identify and assess the readiness of the client for ART, and we are also able to determine the prophylaxis and eligibility for opportunistic infection prophylaxis, if any, that the patient has. So let us start one by one, and let us start with the first assessment, which is the clinical assessment. The clinical assessment is similar as we all have been studying since our 3rd MBBS, and that includes the first part, which is a history taking, followed by a physical examination, and we shall be talking about both of these assessments in detail. It is important to remember that while taking a history from the patient, it is important to obtain not only a general medical history as well as an HIV specific history, meaning you need to ask pointed questions which may help you in identifying opportunistic infections or certain other determinants of disease which are specific for HIV. You must always use vocabulary and language that the patient can understand, regardless of his level of education. So if you are going to bombard the patient at the first visit itself about CD4 and viral load and things like that, it may take some time for the patient to understand and absorb all this. So try and keep it as simple as possible so that the person or the client is able to understand what you're talking about. Always document that the patient is infected with HIV based on what test, where was the test done. Many times patients may walk in or clients may walk in with a report which is not from your linked ICTC. So it is important to remember and identify where the client was tested. Sometimes you may need to retest the client, so that is also important. So you actually need to document that process. One very crucial important information that one must, and we must ensure that the patient actually has a report from an ICT. So that's why I was telling that we need to identify where the test was done, and sometimes you may need to repeat the test from your ICTC. Please always review the past medical records of the person or the client if any. If the patient is carrying it, fine, please spend some time looking at it. Otherwise, you need to maybe ask the person to get any other old records the patient has. However, please remember it is very important to establish a very supportive environment that facilitates the discussion of sensitive issues. There are many issues that you are going to be discussing with a person which could be sensitive, which the person may not like to disclose immediately. So the more the supportive you are and more the conducive the environment is and you are able to build a trust, the earlier and the better it is to achieve a one-to-one trust between the client and the provider. So that is very crucial as part of the history taking. So the components of history taking include history of the presenting complaints with which the person has presented to the ERT center, a detailed assessment of these complaints, an HIV specific history including any history of diagnosis and treatment history. Remember, the patient may have come to you today, but the client may already be infected 4 years back and will not tell you that unless you specifically ask, is this your first detection or have you been detected earlier? Have you taken any treatment for it? Always ask about past medical history and other history, as we shall see in the next slides. So history of presenting complaints, as we know, ask the patient to list out his or her presenting complaints. What has brought the person to the ART center? List them in chronological order meaning the oldest symptom to the newest symptom, and then do a detailed analysis of each complaint including any other associated complaints. Remember that sometimes the person may be completely asymptomatic. He has just come to you because he was referred with an HIV positive report. That is also important to remember because it is always important to understand the context in which that HIV test was done. So it is very crucial. Even if the person is asymptomatic, please ask why were you tested for HIV. So it is important to understand that context also. And so that is also very crucial even though the person may not have any medical complaints. So that is important always to remember. Then when you are reviewing HIV specific symptoms, ask for or inquire about involvement of each or every of these following. Ask about fever, anorexia, weight loss. Ask for skin involvement in the form of any previous rash, pruritus, other skin diseases, lesions or other disorders. Ask about change in vision, color, blurring of vision, double vision, flashes of light, loss of vision, watering from the eyes, redness, which could indicate ophthalmological disease. Always ask for sinus infections, dysphagia, odynophagia, meaning difficulty in swallowing, pain during swallowing, any dental pain or hearing loss, which may suggest ENT involvement. When you are evaluating the pulmonary system, ask specifically about cough, dyspnea at rest or on exertion. Ask for any sputum, hemoptysis, chest pain. Chest pain could also be an indicator of cardiovascular disease in addition to palpitations, exertional dyspnea and the presence of pedal edema. Ask about nausea, vomiting, diarrhea, constipation, blood per rectum, whether there is known past hemorrhoids, any person has noticed any abdominal swellings or lumps, jaundice, which could indicate abdominal involvement. Always ask for history of vaginal or penile discharge, vaginal pain in women, dysuria, genital or rectal warts or ulcers, which could indicate a past STI. Obstetric involvement and gynecological system evaluation is very important. not only gynecological in the form of vaginal bleeding or discharge or infections. If the patient has had a pap smear, it is also important to ask about obstetric history in a woman. Has she had a pregnancy? What was the outcome of that pregnancy? What is the outcome of the children? Has there ever been a termination of pregnancy which was done? Is the person using a contraceptive? Does the person need a contraceptive now? So all these needs to be assessed. Ask about muscle weakness, muscle pain, which could be indicative of musculoskeletal involvement, joint swellings or joint pain. Neurological involvement can be tested by asking about any presence of tingling, burning, headache, focal neurological deficits, seizures, loss of memory, dementia, decreasing cognitive impairment. So all these can be indicative of a prior neurological involvement. When we are talking about pregnancy, it is also important to recognize that the person could have been tested earlier. So was there any past nevirapine taken during the last pregnancy? So we'll talk about that when we also come to the drug history which the patient has taken. It is also important, like I said, the person may come to you today, but the person could have been diagnosed 4 years back and done nothing about it. So always reconfirm the date of the first HIV diagnosis and where it was done and what was the context in which it was done. What was the recent viral load and CD4 count if the person has had any tests done at all? Has the person ever been exposed to ARV? Sometimes patients do not tell about this or reveal this at first, thinking that if they tell you they've had ARV in the past, you might not provide them with ARV. But it is important to recognize that the choice of regimen sometimes is important to realize what ART, if any, the patient has taken. Has the patient has had any adverse reactions to any drugs, not only ART but any kinds of drugs. For example, is a person allergic to sulfonamides? So that becomes very crucial to recognize and understand as far as taking history of HIV treatment history is concerned. It is very important to ask specifically. You have to ask directed questions. Has the patient had shingles or zoster? Is there diarrhea? Has there been thrush? Or has there been any other AIDS defining illness? Similarly, one must always ask about a past STI directly. Has there ever been any STI in the male or female client? It doesn't matter. Always ask about history of tuberculosis. Tuberculosis in the past, tuberculosis presently, or ever been treated for tuberculosis of any kind. Always perform a 4-symptom screening. This has to be done at every visit, but since this is the first visit, you definitely need to do a 4-symptom screening for tuberculosis, meaning check for one of the current fever, cough, weight loss or night sweats. Ask about a history of any past hepatitis or jaundice. Has the person ever had hepatitis or vaccination in the past? These are important to know. It is also important to know about the psychiatric history, whether there has been a past history of psychiatric disease or has the person ever been diagnosed to have a psychiatric ailment. Has there been any treatment of such disease? Is there any disability which is related to the psychiatric disease? And has ever there been any evidence of suicidality in this patient? Ask about a transfusion and blood product history. Ask about sexual history, sexual practices, vaginal, anal, oral sex. What gender does the person identify himself or herself with? These are very crucial issues. How many partners does the patient have? One, many? Are there multiple current partners? Have there been multiple past partners? Try and identify the risk behavior. Does the person use a condom? How many partners are there? But remember, this history can be little tricky to obtain, so you must have a very good trust between you and your client for the client to tell you about these things at the beginning. So that is why in the initial beginning itself I stressed that building a conducive environment is very crucial for asking about such sensitive and specific histories. Always ask about substance abuse history. What type of drug? Was it in the past? Is there evidence of current use? What kind of drugs were it? Street drugs like marijuana, cocaine, heroin, or prescription drugs? Many people tend to abuse prescription drugs like Fortwin, like Phenargan. So please identify what drug is it. Remember, substance use is not related to drug use only. Even alcohol is an addiction. Even tobacco is an addiction. Always ask about the use, the frequency of use, and the route of administration. Assess risk behavior while under influence of the drug. Is there evidence of drug or needle sharing? Is there evidence of exchanging sex for drugs or other high risk behavior while under the influence of drugs or alcohol? And has a person ever sought help for such kind of problems? Also ask about family history. It is very important to understand the type of family that the person comes back, and whether there has been a family history of TB. That is also very important. Past drug history for all kinds of drugs and past treatment history of all ailments is very important for us to understand. Assess the functional status of the patient as far as history is concerned. Is the person able to work? Is a child, if it's a child or an adolescent, is he or she able to go to school? Is the woman able to do the household work? So if if all this is happening, then the person is able to work. If the person is ambulatory, that is able to walk around the house but not fit enough to work or does not feel energetic enough to work, that also should be documented. Or is the person bedridden? It is important to understand that if patients are bedridden, the concept of the importance of the caregiver becomes very, very crucial and very, very important. And the amount of daycare, that the day-to-day care that is required by these patients. So with the help of this, you are able to classify your patients into working, ambulatory and bedridden, which is then entered onto your white card. So that is important to assess the functional status of the patient. Then we come to examination. After looking at the history and after looking at the functional status, we come to examination. And examination, like all of us know, have two components. There is a general physical examination and there is a systemic examination or a system-wise examination. In general physical examination, never ever forget to check the pulse, blood pressure, temperature and respirations. These are the basic information that is extremely crucial for assessment in a patient, and they provide so much information. Always perform an anthropometry, weight, height and BMI. In children, it is ever so more crucial to perform weight, height, BMI and other anthropometric measures, because you need to monitor your child's growth. If you want to do a further detailed assessment of the nutritional status, you may consider mid-upper arm circumference or tricep skin fold thickness under special circumstances. But weight, height and BMI have to be measured. Weight has to be measured at every visit of the patient, and this is very important to remember. In general physical examination, look at the hair, the skin, the eyes, the lymph nodes, the oral cavity, look for pedal sacral edema, look at the ears and do a nose and throat examination. The oral cavity can provide so much information. Look for any oral candidiasis. Look for oral hairy leukoplakia. For this, you need to examine the lateral borders of the lung. Look for gingival disease, gum disease, aphthous ulcers. Look for oral herpes simplex and any other suspicious lesions like a Kaposi sarcoma which could be present in these patients. So this is a 29-year-old HIV positive woman who came with fever and painful vesicular lesions on the lips and angle of the mouth for 3-day duration. If you can see here are the vesicular lesions. There are the vesicular lesions here as well. They are there at the angle of the mouth. They are at the angle of the mouth here as well. So these are very classically seen in patients with herpes simplex, and they are very easy for us to identify. This is something most of us have seen, and this is candidiasis. So if you look here, this person on the left side, the left panel shows oral candidiasis. You can see these white patchy lesions on the inner surface of the lips. They are also there on the gums, on both the upper as well as the lower lips. The right panel shows you far more extensive candida. You can see candida not only on the surface of the tongue, even extending to the lateral surface here. You can also see candidal patches here in the fauces, which means that probably there is pharyngeal involvement, and it is highly likely that this person also has esophageal involvement. It is important to recognize this because this helps you in staging. Oral candida is WHO stage 3. Oropharyngeal candida and esophageal candida actually goes on to WHO stage 4. So it is important for us to stage. This is oral hairy leukoplakia. If you can see, you have these vertical ridges which are there on the lateral border of the tongue. Sometimes it is important to remember that oral candida and oral hairy leukoplakia can occur simultaneously, and you need to be able to differentiate them from each other. Skin examination is also very crucial, gives us a lot of information. Look for seborrheic dermatitis, psoriasis, molluscum, onychomycosis or nail changes. look for folliculitis, pruritus, which are very common in these patients, and also look for herpes zoster or shingles. So if you see this patient, this panel on the left, you can see on the left panel there are these multiple nodular lesions which are seen on the forehead and around the eyes, and these nodular lesions, which all have what is called a central umbilication, are very highly specific and suggestive of molluscum contagiosum. But nodular lesions in the eyes or in the face can also be seen in patients with diffuse or disseminated histoplasma, disseminated cryptococcosis. So you must always keep these differential diagnoses in mind. In a child, there is this diffuse parotid enlargement which is present, and it is quite common, and it is important for you to recognize in these patients. This is something which all of us have seen, and this is herpes zoster. Herpes zoster typically in HIV infected persons is multidermatomal. So you can see that multiple dermatomes are involved, and it is always unilateral. This is multidermal herpes here. Here you can see that in addition, on the right panel, you can also see that in addition to the vesicular lesions, which are so classic, some of them have actually become infected and have become pustular. There is also some amount of scarring which is visible. So it is important to recognize herpes zoster. Herpes zoster again puts the patient, it will help you in staging your patient. Always examine for lymph nodes. Please examine all lymph nodes areas in detail, especially cervical, axillary, inguinal. Do not forget certain other areas like the Waldeyer ring, the epitrochlear, pretrochlear. This is an example of a patient who had multiple nodes. If you can see, these nodes are there everywhere in the cervical chain, and they are actually conglomerate and sometimes matted. So one of the important differential diagnoses here becomes tuberculosis. There could also be a lymphoma. So please always evaluate your patients for lymph nodes. System examination, you need to follow the same scheme of systemic examination, which includes inspection, palpation, percussion, and auscultation of all the systems like we normally do in our, we have learned in our MBBS days. However, we need to focus the examination on the system whose involvement is suggested by the history. But you need to examine all systems in all patients, because many times there may not be history of involvement, yet you may get findings in this. Very briefly, look at the lungs for wheezes, rhonchi, rales, or any dullness or any crepitations. Examine the heart sounds, look for the rhythm, look for the murmurs, clicks, or rubs. This is not in detail, but I'm just briefly telling you. Always examine for hepatosplenomegaly, other masses, look for other free fluid or ascites which is present. Do a detailed neurological examination, look at the mental status of the patient, examine for the cranial nerves, examine for sensory motor abnormalities. Cerebellar function is very crucial to examine, especially if you are suspecting PMLE. Many times they can have cerebellar involvement as the first manifestation. Screen for depression and anxiety. You may need the opinion of a psychiatrist if you feel that person is extremely depressed or extremely anxious. So it is important to screen. A fundus examination, if you are able to do, fine. Otherwise, you may even consider an ophthalmologist opinion for a fundus examination. Genital examination is also crucial and important. You may need to refer to a dermatologist, but look for venereal warts, look for classical herpes or other atypical herpes, look for the presence of any ulcerative or genital lesions and any other evidence of STI. If you want to do a pelvic examination, you may consider a gynecologist opinion if you don't want to do it yourself, and you may also want to look for rectal examination in appropriate patients, and that's part of the examination. But it is important again to remember that it is extremely vital to gain the trust of the patient while establishing a rapport with him and doing the examination. Patients, you need to direct your history in a particular way, because patients may use their own associations and say that I went out in the rain so I have fever, or I went to my sister's house so I developed fever. So while respecting the patient's sentiments, always use your discretion and ask leading questions if it is important for you to understand or gain more relevant history. Remember, personal history, sexual history, addictions are sensitive matters that need to be handled with extreme sensitivity. One may need to spend time with the patients and be very patient in getting these answers. Some matters may actually never be revealed by the patient on the first visit or first assessment, so you may need to reassess these matters again at a later visit. Be gentle while doing a physical examination. Make sure the room is warm and comfortable. Your hands should be warm, especially in winters in North India it gets very cold. Make the patient comfortable, always explain the procedure to the person. And while especially performing genital examination or perineal examination, it is very, very crucial to take consent. This is very important. Sometimes the patient may be too sick or too ill for a detailed evaluation. At that point, a quick assessment of vital signs and relevant examination is all that may be possible before you start appropriate resuscitation measures. However, such patients always need to be reassessed. That is very important. So please reassess these patients at a later time and re-examine them at a later time, but the initial examination must always be done even though it may be rather small. All this assessment clinical should help you identify the WHO stage of the disease, and I am going to run through the next slides which are just talking about WHO stage 1, where the patient is either asymptomatic or has PGL, persistent generalized lymph nodes, more than 1 centimeter node, 2 areas for 3 months. 1, 2, 3, that is PGL or persistent generalized lymphadenopathy. Stage 2, important factors to remember here which mark stage 2 are herpes zoster, angular cheilitis, fungal nail infections, recurrent minor upper respiratory infections, seborrheic dermatitis, and less than 10% weight loss in these patients. Stage 3, here the weight loss goes up to more than 10%, unexplained fever, diarrhea, oral candida, pulmonary TB, severe bacterial infections. These are all stage 3. Stage 4, unexplained anemia, thrombocytopenia again is stage 3. Stage 4 is far more severe disease, patients with HIV wasting syndrome, PCP, chronic herpes simplex for more than 1 month, esophageal candida, extrapulmonary TB. These are all stage 4. CMV, toxoplasma, HIV encephalopathy, disseminated mycosis or fungal infections, PMLE, chronic diarrhea with cryptospora or isosporidia, disseminated diffuse fungal infections, lymphomas, other involvement like cardiomyopathy or nephropathy which are directly related to HIV. So this is how you're going to stage your HIV infection in the patient. So after assessment, one should be able to identify the WHO stage of the patient, identify and suspect any other opportunistic infections, if any, that the patient may have. It is very, very crucial to important to understand and identify any important social, psychological and other factors that may be present in the patient, that may influence the clinical course and that may influence the adherence. It is also important to identify the spouse or children or partners that are there that may need to be tested for the HIV, and it is also important to assess the client's understanding of the illness and readiness for treatment. Remember the cornerstone, and it is very, very crucial to remember, always answer any queries or questions that the client may have during your clinical assessment. However silly you may feel that question is, for that patient or that client, that question is very important. So please always try and answer any queries or question the patient has in a language that is simple for the person to understand. After clinical assessment, we will talk very briefly about what are the laboratory tests. So there are certain tests which are essential or mandatory tests to be done in every HIV infected person once the registration process at the clinic is done. These include a hemogram or a complete blood count, a urine for routine and microscopic examination, a fasting blood sugar, a blood urea and serum creatinine and calculation of creatinine clearance, an ALT or an SGPT, a VDRL. A CD4 count is mandatory in all persons. Even though now we are moving towards ART for all, we still need to have a baseline CD4 count in all persons. Perform a chest x-ray PAView in all patients. If you think the patient could be pregnant and the woman is of childbearing age, if required, you may need to do a pregnancy test. A hepatitis B surface antigen and an anti-HCV antibody. And you may also need to do any other tests as directed by the symptoms and signs of the patient for ruling out an underlying OI. There can be additional tests which may be required depending upon the patient's presentation. You may need to do a liver function test, especially for those who are also on ATT or who have co-infection with hepatitis B or C. You may need an ultrasound abdomen, you may need a CSF examination, you may need a fundus, and you may need any other tests required to rule out an OI. But remember, non-availability of any of these tests should not delay the initiation of ART, and so that is a very, very important point to remember. Many times we have queries saying that the CD4 is not available. Should we start ART? Yes, if you think it must be done, it is very important that it gets done. However, that does not mean that you will not start the ART because the CD4 count is not available. It is also important to remember that testing for hepatitis B and anti-HCV may not be possible at all centers depending upon the availability. However, for some groups it is far more important than for the others. Example, those who are IV drug users or who have abused IV drugs in the past, those who have tattoos, those who have other features of chronic liver disease. So these are very important for certain groups of patients, especially they need to be done. But in others, if possible, do it in all. Otherwise, depending upon the availability, it may be it is to be done. After all this assessment, what we are doing is a couple of things. We are determining the eligibility for OI prophylaxis based on a combination of clinical and assessment and CD4 count. This is important to remember. Sometimes you can start OI prophylaxis, especially secondary prophylaxis, on a clinical history itself. For example, if a patient tells you or a client tells you that there has been a documented past history of cryptococcal meningitis, that is good enough for us to start secondary prophylaxis for cryptococcal meningitis. But the most important CD4 requirement is for determining eligibility for CPT or chemoprophylaxis with cotrimoxazole. So it is important to remember that a CD4 count of less than 350 is important for initiating CPT prophylaxis, and so that is important. That is why you need to do that to determine eligibility for OI prophylaxis. While the investigations are going on and while the investigation reports are awaited, one must take time at this point to get the client undergo ART preparedness counseling. There are 2-3 sessions that the patient needs to undergo. Some patients may need to undergo more sessions if the person is not prepared. But one must take this time, this advantage to make the client undergo ART preparedness. Even though we have now started ART for all, ART preparedness counseling is very, very crucial in all persons, and that cannot be underemphasized. One needs to say that again and again, that ART preparedness counseling is very, very crucial for all of us to understand. Once the clinical assessment, the lab assessment is done, and there are no active ongoing OIs in all patients or any patients, what one needs to do is we must start ART in all. Now all of us know that we have moved towards universal ART or ART initiation in all patients regardless of CD4 count, and so that is why it is very, very important to initiate ART in all. This time period between the testing, the first visit and the investigations, if there are no active OIs that need to be treated, one can reduce this time gap to as less as possible, to 5 to 7 days. But it is important to remember that this is an essential part of the approach or workup of all these clients. It is very, very crucial to understand and to remember that all the while one needs to continue to support the person's patient and his or her family throughout this entire process. And so that is probably the cornerstone of all this approach to the patient and the client. If there are any questions, I would like to take them now, and I think that was the last slide. So if there are any questions anybody has asked about any point, I would be very happy to take them. As of now, we have not received any questions from anybody, but it is important to remember that approach to a client who is HIV infected means we are assessing so many aspects of HIV infection the clinical aspects, the social aspects, and also other aspects, psychosocial illness. Yes, I think there is a question from somebody. Let us wait while it gets typed. So assessment does just not mean history taking and a physical examination and handing over a few slips for investigations. It is an overall complete assessment of the client that will help us understand not only that person but also his social environment, which is very crucial, and like I said, sometimes, many times, it is not addressed properly. Alright. The first question I am having is treatment of resistant and recurrent fungal infections. Okay, I am not very clear on the question, but if the person has resistant or recurrent fungal infections, then you need to treat it appropriately in consultation with your dermatologist. If it's a skin infection, it may need, sometimes these treatments need to be prolonged. Sometimes we have found that patients even have resistant candida infections where azoles are ineffective, so you may need to give other types of therapy. For example, we have even given amphotericin B, but this has to be done on a case-to-case basis. It says, when in practice and time does not permit all of the points discussed here in one go. I completely agree, and like I said, you can't do probably all of this in one time. But this is the approach that has to be followed. You may do it on a subsequent visit. You may determine certain factors on a next visit. That is why the first assessment and the first few assessments have to be done by multiple people, including your counselor, including your staff nurse, including yourself if you are a doctor. So I understand the problems with time constraints, but it is very important and crucial to remember that at some point of time all these information need to be done. And it has to be done in all persons, because that means that is what is meant by comprehensive HIV care. Comprehensive HIV care means not just providing ART, it means comprehensively looking at all aspects of HIV infection, including linkages to other programs and other services and other schemes which will be of benefit to the person. What is the CD4 count required to start OI prophylaxis and stop? Well, for CPT prophylaxis, the CD4 count cutoff is less than 350 and you can stop it after it is more than 350 for 6 months, that is 2 intervals. Alright. Madam, in initial PPT, I have a question. Whom a new PLHIV approach for assessment and registration? When the client walks into the ART center, the first person the client will generally meet would be the care coordinator and the staff nurse. So they need to start the process of bringing the client inside the services, then informing the client how to go about and what are the procedures. Then the client will go to the counselor, then be seen by the doctor. So everybody has a role, but it has to be done in a streamlined manner and so that all aspects of information are approached to. In what OIs the ART is to be delayed till control of OI? So that's important to ask, and that is important to remember that certain opportunistic infections have to be treated before you can start the treatment or antiretroviral treatment. This includes PCP and toxoplasma. Patients with cryptococcal meningitis need to be completing their induction phase, start their consolidation phase, and must be stable before ART is initiated, otherwise there is a risk of iris. For patients on TB or patients who have tuberculosis, ART initiation should be done as soon as possible, preferably within 2 weeks. That once you start ATT and the person is stable, you should start ART as soon as possible, preferably by 2 weeks. The guideline says that in patients who have very low CD4 counts, you can initiate even earlier if your patient on ATT becomes stable. So that is what is meant. And the only problem is if the OI is not treated and you start ART, the risk of immune reconstitution inflammatory syndrome or iris becomes very, very high. So that is why OIs need to be treated and then you can start ART in these patients. What about the drug availability for treating all HIV positives? I am not sure about what this question means, but what I think it means is whether ART is going to be available for treating all HIV infected. Yes. The drug regimens are not changed, they are the same, that irrespective of or regardless of CD4 count, we are going to start treatment, and so drug supply will be augmented and will be taken care of at all ART centers. And so I think that is the question I can understand from that question. So there are more questions which are getting typed. Can you please suggest prioritization strategy? Prioritization strategy, I am not sure for what. Does it mean what needs to be seen in a patient or in a client at the earliest? Well, you have the same process. The registration has to be done, then counseling, and then seen by the doctor for a clinical assessment. These can be done on the first day. Then the lab assessments can be done later when the lab slips are provided. In the meantime, you can look and screen for the OIs. That should be done. That is the priority. I think that is what is meant by this question, and that is how I can probably answer this question. As far as prioritization of which client needs to go in first, well, of course, pregnant women, children, people who are coughing in the ART center, they need to be fast tracked. You know this. And so this is what is mean by prioritization as far as fast tracking into the ART center is considered, and I think that is what is meant by prioritization strategy. We are waiting for still more people as there are still more questions coming in. So like I stressed again and again, I'm going to say it again, that assessment of a person, of an HIV positive client, does not just mean clinical assessment. It means a comprehensive assessment involving many facets of the person so that comprehensive HIV services can be provided to these clients. I am not seeing any more questions, but there still seem to be some people typing in some questions. Okay, so as we are taking questions, we need to also understand that, like one of the questions which were asked is that time does not permit, so we cannot ask all these questions in one go. I agree. So it is important to recognize that yes, not all questions can be asked in the first go, but they can be asked in the further involvement of these patients, and so that is important. Okay, there are two more questions which have come in. The first is that in a patient on ART treatment, why HIV-2 test is done and what are the benefits to the patient? The benefits, HIV infection could be because of HIV virus 1 or HIV virus 2, and so it is important to recognize which HIV infection person has, one or both. So that is important, and or a patient is co-infected, and then the treatment will vary, or the ART actually varies and differs for those who have HIV-1 infection versus those who have HIV-1 and 2 or HIV-2 alone. For HIV-1 infection, we are using an NNRTI based regimen. For HIV-2 infections, we are using a PI based regimen since NNRTIs are ineffective in such patients. Alright, so there are a couple of more questions that were here. Alright, why is HIV test 2 test done? Okay, when are we starting IPT prophylaxis to those patients who are on ZLN for many years without any side effects? They are becoming anemic. How to explain this? Alright, so these are two things which are there together. I don't know, there are a couple of questions. Yeah, so okay, Dr. Rivari has answered for one question, that can ART be started in all patients? Well, he says yes, Start drugs for all. Drugs will be provided for by NACO. Thank you. That is important. Like I said, drug stock management is an important issue that NACO will take care of, and I'm sure that they will provide drugs for that. Now, I have a question that for those patients who are on Zedaline for many years, suddenly they become anemic. How to explain? It is important to remember that anemia which is related to Zedaline generally happens in the first 8 to 12 weeks. If patients are developing it much late, please remember these patients could be manifesting first line failure. So please evaluate these patients for a SASAP mechanism for probable first line failure. So that is important, very, very important for you to recognize that it is possible that this anemia is not related to zidovudine induced anemia, rather could be a manifestation of a first line failure. There was a question about stavudine side effects. Stavudine, well, it causes many side effects, and stavudine is no longer part of our first line. However, stavudine can give rise to lipoatrophy, lipodystrophy. Stavudine can give rise to peripheral neuropathies. It can give rise to pancreatitis in certain patients. And there can be other, and it can give rise to lactic acidosis. So these are some of the questions, some of the side effects with stavudine. I'm having a couple of more questions. A patient is admitted in the hospital and a relative has come with an ICTC report. When should start ART in such a case? See, it is very important to recognize that why is the person admitted in the hospital? So if a person is admitted and hospitalized, you cannot start ART until you know what is happening to the person, isn't it? In more probability, that person is admitted because the person is having an OI. So then you need to recognize and find out what OI is happening. So it is better if you ask the person to come with records, the attendant to come with records. If the patient is too sick, the patient may not come. But it is, in such a situation, it is very, very crucial to find out why the person has become admitted to the hospital, why he or she is hospitalized, is there an underlying ongoing OI, and then that time that OI needs to be treated first. There is another question, since when does test and treat strategy come? Well, test and treat strategy has already come. I am sure all of you should have received the memo from NACO. If you have not received, please, I will ask the local regional coordinator or the SACs to provide you with the memo. That test and treat policy has already been launched by NACO, and you should have received the office memo in this situation. Dr. Rivari has also suggested that the counselor may visit the patient in the ward in the situation the person is admitted, and maybe the medical officer. That is possible if it is in the same hospital, but if the person is admitted somewhere else, well, possibly you cannot go. But however, if it is possible, if not go, at least try and get the reports or the file. That's what I said in one of my earlier slides. Please look for medical records. Always look at the medical records. If the person is admitted in another hospital or another ward, just ask the person to bring the file or the records. It will give you so much information. That is all. Dr. Rivari has again said that he is going to take a session on 31st May on test and treat, and so there you have it. You will have far more information at the next NDLS. So that is what is there. But please, all patients who are there in your clinic, who are registered or who are getting registered, anybody who is HIV infected now needs to go on ART regardless of clinical stage, regardless of CD4 count, after ruling out and treating OIs, and after initiating CPT, and after counseling and ART readiness. So I think we have taken almost all questions, and it has been okay. ART Center Gokak Karnataka have not received the memo. Please, somebody from NACO, if he or she is there, please send them the memo for treat all. They seem to be unaware of that. So somebody will send that to you. We will make sure that it reaches you. So now I am getting a lot of thank you. So thank you very much for listening in today, and it was wonderful listened, and we have discussed so many good issues. Thank you very much. Thank you once again.
Thank you, ma'am, for such a comprehensive and informative sessions. Thanks to all the participants for patient listening. All the participants are requested to kindly enter the e-poll which is going to display on the screen shortly.